Okay, class. Now we move on to another topic, which is suturing. Suturing, as you know, is an important topic because in dentistry, we do extraction and we do incision, and then we need to approximate the edges of the wound. Okay, so from this lecture, the learning outcome would be suturing's definition, indication, contraindication. Then you have types of sutures, various names will be there. Surgical suturing instruments, then you ought to know the basic ones, surgical suturing needles, also various needles and sizes. And furthermore, the types of closures that you can attain from the suturing technique. Okay, a suture is a thread of material used to ligate vessels and reapproximate lacerated or incised tissue. It's a sort of a thread lah. In common language, you call it thread. Surgical suture materials are used in the closure of most wound types. The ideal suture should allow the healing tissue to recover sufficiently to keep the wound close together once they are removed or absorbed. That means the sutures are removed or they become absorbed, the wound that is healed should remain intact. Surgical stitching is a process to close a wound or incision or to approximate parts and play a significant role not only in obtaining primary closure for ideal healing. The suture will coap. Coap means bring together the two edges of the wound margins to hold the tissue in position and approximate the opposing wound edges. The sharper the incision and less trauma inflicted on the wound margin, the more probable is healing by primary intention. That means it will produce good result, minimum scarring. If the space between the two wound edges is minimal, wound healing will be rapid and complete. If tears or excessive trauma to the wound edges occur, wound healing might need to occur by secondary intention. Okay, what are the indications to use sutures? Well, the repairs the skin tissue when there is a wound or injury on the skin, and it also facilitates proper skin healing. Like I say, it will produce a nice scar, or it will not, if it's not well done, will get a keloid that's unsightly to see. And also, the reason for indication for suturing is to minimize bleeding, minimize bacterial contamination, that is infection. We minimize infection, helps achieve skin hemostasis. That means we achieve bleeding is stopped. That means the bleeding will be stopped. Restores the normal function of the injured body part, produces pleasant cosmetic results. Okay, principles of suture selection, it depends on the healing characteristic of the tissues. If it's like whether the skin or the subcutaneous or the muscle or the tendon or the muscles that are involved or the nerves which are approximated. The physical and biological properties of suture material also will give indication towards what type of sutures to be selected. The condition of the wound to be closed, the probable post-operative course of the patient. The ideal suture can be utilized in any operation. It can be handled easily and comfortably, minimal tissue reaction, high breaking strength. That means it doesn't break easily when you tie a knot, and the knot security. Then when you tie a knot, it stays in place. It does not cut, tear, or shrink the tissues during the suturing procedure. It's a non-allergic, non-carcinogenic. These are quite important. That means it should be an inert material. It is also absorbed predictably with no tissue reaction. It is reasonably priced. Money matters. When you buy cheap, people will buy cheap and good. Okay. Sutures physical characteristics. The physical configuration could be a monofilamentous or multifilamentous. That means a single filament or many filaments together. It could be twisted or braided. Twisted means there's only two filaments are involved. A braided means more than two are involved and they are braided. The tensile strength of a suture depends on the cross, it depends on how on when it breaks. Identified by different number of zeros. For example, usually the one we use in clinic is 30. That means it is 3 stroke 0. Or the one just zero only. Just one zero is much more stronger than three zeros. Okay, the smaller the number of zeros, the strong is bigger. The knot strength also depends the amount of force needed to cause the knot to slip. That means after tying a knot, it just slips. It is proportional to the coefficient of friction of the material. That means if there's a friction in the material, then the knot will not open or slip. The elasticity, the ability of the suture to regain its original format length after being stretched. Each time you suture, you pull out the thing, you're just stretching it, but an ability for it to go back to its original size. The plasticity, the ability of the suture to expand when stretched, but not to return to its initial length. The memory of the suture, the ability of a suture to return to its former shape after being manipulated. It's the reflection of its stiffness. You know, when you're suturing, you're pulling the threads here and there, and then if it cannot go back to its original size or plasticity, it's not a good suture. Classification of suture material. Okay, now we know these sutures are like thread. So we want to know according what it is. So according to the suture, what is it for? Okay, like for example, according to the fate means is it absorbable or non-absorbable? Absorbable means you don't need to do a STO to take out the suture, but itself it get resolved. Or non-absorbable, you need to do STO to remove the suture. So according to the source, how is the suture obtained? Natural or synthetic in the factory or what? According or from animal structure. According to suture, according to the structure that we are going to use the suture for, monofilament or multifilament. According to the coating, coated or uncoated, dyed, undyed. Dyed means the color, usually the color, the purple or what. According to tissue reaction, there's any reaction while using the suture or there's no reaction. According to handling, is it easy or difficult to handle the suture? Thick or is it not plastic or elastic? So instrumentation, to do suturing, you need some instruments. First of all, you need a needle holder. The needle holder is an instrument with a locking handle and a short blunt brick. For intraoral placement of intraoral sutures in the mouth, that means you require about 6-inch or 15 centimeter needle holder is usually recommended. The beaks of the needle holder are shorter and stronger, and the face of the beak of the needle holder is cross-hatched to permit a positive grasp of the suture needle, increasing the control over the needle and the suture. This is how a needle holder looks, cross-hatched, and then when you work, you can hold the needle. To control the locking handles of the needle holder properly and to direct the beaks of the needle holder, the surgeon must hold the instrument properly. The thumb and the ring finger are inserted through the rings of the needle holder. The index finger is held along the length of the needle holder to steady and direct it. This will aid in controlling the locking mechanism. The index finger should not be put through the ring finger because this will result in dramatic decrease in control. So the right position is the thumb and the other finger, as we're showing here now. The thumb goes through the ring, one ring, and then this finger goes through the thing. And the index finger is to guide. And we have scissors to cut the suture after having tied the knot. Tissue forceps, for example, you have Adson's fine, Adson's tooth or non-tooth, or fine or not fine, Adson forceps. Or we just call it the word in the surgery pickup. A pickup is a forceps. Find a needle holder. Tissue forceps, adsense forceps, or pickups. These are delicate forceps with or without small teeth at the tips, which can be used to hold tissue gently and thereby stabilize it. Care should be taken not to grasp the tissue too tightly, crushing the tissue. Tooth forceps allow tissue to be held with a more delicate grip than a non-tooth forceps. Surgical needle. Anatomy of the surgical needle. Surgical needles used during surgical operations can be found in many different sizes, many different types, and in different shapes. The needle size is an important factor for a successful surgical operation. The needle should move through the tissues with minimal tissue reaction and minimal tissue damage. All of the surgical needles used today are eyeless needles. That means not the one that we use in our clinic where we have an eye at the needle and we thread in the suture, black seed suture, and we tie a knot. But the one that we're using outside in the surgery, they're eyeless needles. Sutures are combined with needles during manufacture by the manufacturer by creating a channel for the suture at the tip of the needle. The needle and the suture are combined for a smooth transition. It'll just go through easily. If you have a knot there, it acts as a hindrance for the easy transition of the needle through the tissues. The needle and suture thickness has a thinner structure compared to the eye needle. This surgical needle is called a A. Okay, now the size. Suture size is commonly indicated by the United States Pharmacopoeia (USP) system and is a measure of the tensile strength as well. Tensile strength is defined as the amount of weight required to break a suture divided by its cross-sectional area. In the USP system, the number of zeros inversely correlates with the size. The higher the number of zeros, the smaller the size and the lower the strength. For example, a 3-0 suture has a diameter that is approximately 2 or 4 times larger than a 6-0 suture. 6-0 suture is usually used in the eye in your cataracts where the lens implanted. In plastic surgery repair of cleft lip and cleft palate, we use 5-0 plastic needle. In general, larger the suture size is associated with greater inflammation and scarring. This is what it gives about. So you use finer needle, you get less scarring, less inflammation. This diagram shows you the type, the names of the parts of the needle. Needle body, needle diameter, swatch, needle cord length, and needle point. Needle shape. There are straight needles. This surgical needle, which can be used without a needle holder, is generally used in easily accessible tissues. Fortunately, we don't use in dentistry. We use curved needles. Quarter circle needle. The surgical needle used in a convex surface and sensitive surgeries has slight curvature. It's got a slight curvature, a quarter circle. 3/8 circle needle. They are needles generally used in large and superficial wounds. 3/8, okay? The half circle needle, the areas of application such as tissue, such as skin, muscle, peritoneum, and the eye. Half circle. From my experience, half circle easily it goes through the tissues and out. Okay. The 5/8 circle needle, these needles which are easier to maneuver in smaller areas where you have accessibility limited are mostly used in deep and close cavities where you are to suture the muscle layer or the area deeper inside. The J needle is used in cleft palate surgery and laparoscopic surgeries with deep incision. Here, I'd like also to point out that it's a preference of choice. I do cleft lip, cleft palate surgery using P needles, plastic needles. They're not plastic, by the way. They're just given the letter P. Commonly, surgical needles are made from stainless steel. They are described as the swagged end connects the needle to the suture. The needle body or shaft is the region grasped by the needle holder. Needle bodies can be round, cutting, or reverse cutting. Round bodied needles are used in friable tissue such as liver and kidney. Cutting needles are triangular in shape and have three cutting edges to penetrate through tough tissues such as skin, sternum, and have a cutting surface on the concave sides. Reverse cutting needles have cutting surfaces on the convex edge and are ideal for tough tissues such as tendon or subcuticular tissues and have a reduced risk of cutting through tissue. Needle points for use on the skin and triangle. Reverse cutting is located on the outer convex surface of the needle and the perpendicular to two other opposing edges. This type of needle is preferred for most skin closures. That means a reverse cutting needle. Conventional cutting, the cutting edge is located on the inside concave curvature of the needle and is or perpendicular to two other opposing cutting edges. This needle type may be prone to cut out of the tissue because the inside cutting edge cuts through the edges of the incision or wound. Thus, conventional cutting needles should be avoided for closure of skin laceration. These are the various shapes of sizes of the cutting needle: a tapered point, reverse cutting, conventional cutting, and taper cutting. Okay. For most traumatic surgery skin lesions, the clinician should choose a suture needle with the following characteristic. It should be a reverse cutting, 3/8 curvature, labeled for use on the skin. FS as standard skin needles such as FS for the skin or CE cutting edges series are suitable for closure of the scalp, trunk, and extremity lacerations. Plastic needles are smaller and more sharply honed for use during closure requiring precise approximation. Example, facial lacerations are indicated by acronyms such as P plastic, PS for plastic skin, PC for plastic uh, cosmetic, and PRE for plastic reconstruction. Suture material. The requisites for suture material it should be high uniform tensile strength, permitting use for finer sizes. Securely throughout the critical healing period, followed by rapid absorption. Sterile, pliable for easy of handling and tying of the knot. Biologically inactive. Freedom from irritating substance or impurities for optimum tissue acceptance. Predictable performance, where we can predict the form of the material we use is suitable. Prevent or limit bacterial adhesion and proliferation. And it should also have uniform diameter and should be non-carcinogenic, non-allergic. Suture material again is broadly, sutures can be classified into absorbable or non-absorbable material. That means absorbable, you don't need to come back for a suture removal. Non-absorbable, you need to come back for suture removal. They can be further subdivided into synthetic or natural sutures and monofilament or multifilament sutures. The ideal suture is the smallest possible to produce uniform tensile strength, securely hold the wound for the required time for healing, then be absorbed. It should be predictable, easy to handle, produce minimum reaction, and not securely. This is what we mean by that. Sutures, absorbable, non-absorbable. Absorbable can be synthetic, natural. Non-absorbable can be synthetic and natural. Okay? These are the type of examples. Absorbable sutures, they are made from naturally occurring materials that break down when placed in the skin. Enzymatic reaction or hydrolysis in the body brings about their absorbable. Chromic catgut, which consists of processed collagen taken from the submucosa of animal intestines. Okay, that is catgut. It's very misleading when you talk of catgut because the people think it's from the gut of the cat. No, it's from the cow or the sheep. And then the absorbable sutures breaks down after 7 days, but it is treated with chromium salts to delay the process, allowing it to maintain its strength for up to 2 to 3 weeks. Like you said, it can break down, but then because it's coated with the chromium salt, it prolongs its breakdown. Completely absorbed by the body. Example, Vicryl repite 42 days it will be there, and by 42 days it will be over, and there's a just Vicryl only. That is it stays in 60 days, monocryl or 100 days. Synthetic absorbable sutures, example Vicryl and monocryl polymers, which are broken down by hydrolysis. And then you also reduce tissue reaction that they have been linked with chromic gut. Non-absorbable sutures, these are made from silk, nylon, proline, and muslin. They cannot be broken down by the body enzymes or even through hydrolysis. They are removed once the skin has sufficiently healed and regained its tensile strength. The skin has regained its tensile strength up to a certain extent. They are removed by using a scissors and using a forceps to hold the ears of the suture. Non-absorbable sutures are used to provide long-term tissue support, remaining walled off by the body's inflammatory process until removed manually if required. The specific length of time that the suture is removed is different in every situation but tends to follow a general pattern depending on the location of the sutures. The specific length of time that the suture is removed is different in every situation, but tends to follow a general pattern depending on the location of the sutures. For example, facial sutures are removed within 3 to 4 days, while the scalp and skin tissues sutures are removed in 5 to 7 days. Usually, we take about 5 or 7 days. We keep it there longer, so okay. Synthetic versus natural. So the suture material can be further categorized by their raw origin, whether it's a natural or made of natural fibers, example silk or catgut, less frequently used as they tend to provoke a greater tissue reaction. These natural things are less frequently used because they tend to provoke a greater tissue reaction. So synthetic are comprised of man-made material, example PDS or nylon, tend to be more predictable than the natural sutures, particularly in their loss of tensile strength and absorption. And also they are less reactive. Okay, monofilament versus multifilament. Suture materials can also be sub-classified by their structure. Monofilament suture. A single-stranded filament suture, example nylon, PBS or proline, have a lower infection risk but also have a poor knot security and ease of handling. Multi-filament suture made of several filaments that are twisted together, example braided silk or Vicryl, and it's easier to handle and hold their shape for a good knot security, yet do not harbor infection. So these are type of sutures: absorbable, non-absorbable, monofilament, multifilament. Wound evaluation. Then before you use any suture material, you must evaluate the wound. How was the wound or injury created? Mechanism of injury. Wound age, that means how long has the wound been there or has not been sutured. Degree of contamination, presence of a foreign body, like a gunshot wound. Have they removed the shell there or not? Wound size and depth. Presence of neurovascular comprise injury to adjacent structures, need for tetanus prophylaxis, potential for impaired wound healing. Contraindication for primary closure: laceration, for which suturing will significantly increase the risk of wound infection, are lacerations through infected skin, deep puncture wounds, laceration that have been grossly contaminated with foreign debris. Superficial wounds that would be expected to heal without significant scarring, such as lacerations or abrasions that only involve the epidermis. Suturing in these wounds will potentially cause increased scar formation and risk for infection. Lacerations with significant tissue loss. These are contraindication. So much tissue loss, how are you going to close it? So maybe you have to leave it and heal by secondary healing. Wound management, you need to do a cleansing of the wound area, debridement, hemostasis, closure, and supportive therapy. Cleansing of the wound, you use local anesthetic to reduce pain. Wound debris should be removed prior to dressing. Application to facilitate both repair and assessment. Performed by normal saline sterile solution. Uh, okay. Performed by normal saline, which is a sterile solution, and is non-toxic and no adverse effect on healing. You could also use diluted hydrogen peroxide oxidizing effect. The effervescence of it will destroy anaerobic bacteria and remove slough from the wound. Chlorhexidine mouthwash, broad spectrum antimicrobial agents. It increases bactericidal and reduces bacteriostatic bacteria. Povidone iodine is a broad spectrum antiseptic, bactericidal activity. Debridement of wound, reduced number of bacteria in the wound, removal of devitalized tissue, and jagged pieces of wound surfaces. Improve blood supply to wound edges, better tissue approximation during closure. Hemostasis in wound, direct pressure. When you apply pressure is sort of stopping the bleeding from going on. Now, fracture reduction is the mandible is fractured. We try to reduce the fracture so that the bleeding stops. Hemostatic agent can use bone wax, Surgicel, or adrenaline soaked in gauze. Or you just can use a local anesthetic and just spray it on the area where you are doing the suturing. Bleeding of blood vessels should be clamped or tied with ligatures. Cauterization can be electrical, chemical by using a solution known as Carnoy solution, or you use sutures. That's how you stop. Closure of wound. Closure of wound with suture could be absorbable intraoral inner layer of the wound. Example as Cefil, Vicryl, Dexon. These are brand names. Non-absorbable extraoral wound, you use Ethilon, Black Silk, or Silk-Chem. Wound with greater tissue loss may need to be undermined to minimize wound contraction. You undermine the tissue so that there's less tension. Deep wound layer by layer suturing, whether it's muscles involved and there's cutaneous tissues involved, cartilage involved, then you have to do layered suturing. Through and through wound suturing, start intraorally to prevent pooling of saliva in wound, minimize wound contamination. When you have a through and through wound from the cheek outside into the mouth, you start from intraorally, do the intraoral first, then you come outside because the saliva just keep on moving if you do it from inside out. So it's better to do it from inside out, minimize wound contamination. So now we have come to closure of the wounds. Closure of the wound with suture can be this. Principle of suturing. Principle of suturing technique, the needle holder should be grasped the needle approximately 1/3 of the distance from the hand. See the diagram. The needle should enter the tissue perpendicular to the surface If the needle pierces the tissue obliquely, a tear may develop. We don't want to tear the tissues. Inserting a suture. In general, place the first suture in the middle of the wound. Load the needle holder, grasp the needle at 90 degrees angle with the very tip of the needle holder. Grasp the needle at the junction of the proximal and middle third of the needle. Use the tip of the forceps as a hook or use a skin tissue hook to gently lift the tissue and invert the wound edges as needed while the sutures are being placed. Proper wound edge inversion during this step is essential to get optimal approximation of the dermis, which ultimately helps maximizing the strength and minimizing scar of the healed wound. Place sutures by gently supinating your wrist so that the needle follows its curvature through the skin. The needle should enter and exit the skin at 90 degrees angle. As the depth of the bite width on both sides of the laceration, the bite depth should not be greater than the bite width. Push the needle through both wound edges. Gently pull the suture through the path of the needle and leave some, example 2 to 3 centimeter of the free end of the suture material exposed. Release the needle from the needle holder and allow the needle to rest on the sterile drape. Tie the suture using the instrument tie. Repeating these steps, place all subsequent sutures in the middle of each open section until there are no more remaining gaps in the wound. Spacing between sutures is typically equal to the distance from the needle entry to the wound margin. Instrument tie. Hold the tip of the needle holder above and between the entry and exit sides of the suture. Use your non-dominant hand to manually hold the long end of the suture. To lay down the first throw of the knot, wrap the needle and long end of the suture over the end of the needle holder twice. Wrapping twice forms the base for the surgeon's knot, which prevents the first from loosening. Next, rotate the needle holder 90 degrees and if you grasp the free short end suture. Pull your hands in opposite direction to lay down the first knot, securely but not tightly. Tight sutures risk cutting into the skin and causing ischemia as wound edema develops around over the next several hours. On the second and subsequent throws of the knot, wrap the needle end of the suture over the needle holder only once. Grasp the needle end of the suture with the needle holder and pull it opposite direction to tighten the knot. These subsequent throws may be pulled tightly. Note that the suture is always drawn over the needle holder and that your hands move in alternating direction across the laceration with each throw. Adhering to this method ensures that all knots are square knots. Place a total of about 4 throws. After the final throw, cut the suture with the scissors, leaving tail ends of 1 centimeter long. Suturing principle. The needle should be passed through the tissue following the curve of the needle, curvature of the needle. The suture should be placed at the equal distance from the incision on both sides and at an equal depth. The needle should pass from the free tissue to the fixed site. If one tissue site is thinner and the needle should pass from the thinner tissue to the thicker one. If one tissue plane is deeper than the other, the needle should pass from the deeper to the superficial side. The distance that the needle is passed into the tissue should be greater than the distance from the tissue edge. Avoid excessive tissue bites with small needles, as it will be difficult to retrieve them. The tissues should not be closed under tension since they will tear or there will be necrosis around the sutures. If tension is present, the suture should be undermined to relieve it. The suture should be tight so that the tissue is merely approximated and the edges are everted. The knot should not be placed over the incision line. Sutures should be placed approximately 3 to 4 mm apart. Closer spaced sutures are indicated in areas of tension. Knot. Components of a knot. The loop created by the knot. The loop created by the knot. The knot itself, which is composed of a number of tight throws. Each throw represents a weave of two strands. The ears, which are cut ends of the suture. Square knot. This square knot is made by tying two overhand knots, each done in opposite direction. For example, the first loop is made by making a loop over the jaws of the needle holder, and the second knot is subsequently made by forming a loop under the jaws of the needle holder. This knot is easy to tie but may loosen, and a synthetic or monofilament suture is used when a synthetic or surgeon's knot. This knot is used primarily with braided suture material, whether synthetic or natural. The surgeon's knot is a modified square knot in which the first overhand knot is doubled. Therefore, two loops of the suture are formed over the jaws of the needle holder and tightened. The last loop is formed under the jaws of the needle holder in a direction opposite from the first loops. Suturing technique. Suturing technique: simple interrupted suture, continuous subcutaneous, interlocking suture, continuous skin suture, mattress suture, and buried sutures. Simple interrupted sutures are individually placed and tied. Needs to be repeated for many times as required depending on the wound length. Less potential for causing wound edema. Allow the surgeon to make adjustments as needed to properly align wound edges. Technique of choice if cleanliness of wound is doubtful. If the wound appears to become infected, a few sutures can be removed without interrupting the entire closure. So when you remove one or two sutures, you can remove the exudate that is being formed because of the inflammation. So the wound still is in tight. Disadvantage: more time is required to place the interrupted sutures and more risk of cross-hatching train tracks across the suture line. The latter can be minimized by suture removal, early suture removal. Simple interrupted suturing sutures produce strong and can be used in areas of stress. Each suture is independent and the loosening of one suture will not produce loosening of the other. A degree of eversion can be controlled, easier control of infection and of hematoma. Continuous subcutaneous suture is a more resistant than a simple suture. Continuous sutures may be performed more rapidly than simple sutures. Useful in situations with minimal wound tension and dead space, and when the best cosmetic result is desired. So you use continuous suturing technique. Can result in minimal visible suture marks, little cross-hatching, as well as closely approximated wound edges. Does not contribute to wound strength. There is a risk that a wound may split or burst open if the suture breaks. This is a diagram showing you how we do suturing. Continuous interlocking suture, a variation of the continuous subcutaneous suture. The interlocking suture technique provides extra resistance. It retains most of the tension, thus enabling surgeons to perform a tension-free skin suture. The interlocking suture also acts as an anti-slippage suture. In this suturing technique, threads provide higher friction at each passage, which in turn gives a firmer hold during the suturing. It also ensures that when stitches will not loosen when the next passage is performed. The continuous subcutaneous interlocking suture has high tensile strength, which is extremely useful on wounds under high tension or in case of highly vascularized tissues requiring additional hemostasis. This technique of sutures can impair microcirculation and cause strangulation with this interlocking thing. It should only be used in areas that are adequately vascularized. This is how it's done. Continuous skin suture is primarily used with tension-free wounds, in which deeper sutures are placed so as to minimize the wound tension. Typically causes less scarring as it involves the use of lesser knots. Continuous skin sutures are also placed rapidly, but there is also the risk that the wound may burst open if the suture breaks. The continuous skin suturing technique is generally used for securing the perimeter of a split or full thickness skin graft. Continuous over and over suture provides a rapid technique for closure, distributes the tension uniformly over the suture line, offers a more watertight closure. This is how it's done. This okay. Mattress sutures over when used, wound edges are not close to each other, thus allowing tension-free healing. To ensure the eversion of the wounds and to minimize substantial wound tension, are predominantly used in areas in which the edges of the wound tend to be invert, for instance, wounds on the concave surfaces. This suturing technique has two variants, that is horizontal and vertical mattress suture techniques. The horizontal suture helps with minimizing wound tension and closing deep spaces. It also facilitates wound edge eversion. The vertical suture, on the other hand, is regarded as one of the best suturing techniques that ensure wound eversion while also reducing wound tension and dead space significantly. This is how it's done. And you have buried sutures, a useful technique for wide gaping wounds and wounds where eversion is difficult. The purpose of this stitch is to line up the dermis and enhance healing. The knot needs to be as deep into the tissues as possible. That's why it's called buried, so that it does not present through the epidermis and cause irritation and pain. This suture is extremely important for distributing wound tension to the dermis rather than to the epidermis, and also for closing dead space. It provides longer term support to the healing wound and improves the cosmetic results. The wound edge is everted with a skin hook, and then absorbable suture is introduced at the subcutaneous level and brought back out at the dermal level on the same side of the wound. The needle then enters the same dermal level on the opposite side of the wound and exits in the same subcutaneous level as it was initially entered into on the first side of the wound. This knot is tied deep and the subcutaneous level and free ends are cut short, usually for muscle or fat layer when you want to suture. The most commonly used suture technique in dentistry is the simple interrupted suture as shown above. Then you have the internal vertical mattress suture. Then you have the horizontal mattress suture. It shows there usually for sockets after extraction. You have a figure of 8 suture. This is commonly used when the socket is packed with gel form or Surgicel. The needle is passed at the distobuccal papilla through the mesiolingual papilla, through the distolingual papilla, and you get a figure of 8 there. This is a sling suture. Supportive therapy, analgesic tetanus vaccine post-surgical diet, wound care, and antibiotics. How do we do an STO? So that when we cut, we pull the tissue, the part of the suture which is inside out, not from outside exposing suture material goes through the internal. No, the other way around. Okay, this diagram shows it. Complication, you can get scarring, infection, keloid formation, poor skin healing, ischemia and necrosis due to excessive tight suture. Thank you.